very important because the fetal movements, 40% of all pregnancies, 40% of women who've experienced less fetal movements during some time in the pregnancy are transient. However, when there's a significant reduction or alteration in the fetal movement, this has been shown to be a potentially important clinical sign. Even sometimes absent fetal movements can be a warning sign of impeding fetal death. So a lot of times using ultrasound studies of fetal physiology also have been associated or been shown to be associated with when a woman complains of reduced fetal movements and actual poor perinatal outcome. And all these are from studies that have been published. And a study has showed that 55% of stillbirth, the women have come to complain about less fetal movements. So this is the population we're trying to target, the women who do complain and might be at risk of having a stillbirth. Also, our inappropriate response to the reduced fetal movements has been shown to be a contributory factor in numbers of stillbirth. All of these are been publications about this topic. So there are many types of movement. In early pregnancy on the ultrasound, you can see the baby having a jerking or a jumping movement. Respiratory movements can be seen as soon as early 18 weeks. Simple movements are especially the movements that the mothers feel when it's a primary after 16 weeks, when it's a woman with many babies after 16 weeks, when it's a first-time pregnancy, usually after 9 weeks, where they can feel the kicks, the limb movement, the rolling movements, sometimes hiccups, and hiccups can be sometimes a concern for some mothers, because once they go online and read, and then they read all these that the baby's unwell and they come because they're worried. But no, actually it's a type of a normal movement. Suckling also has been shown on ultrasound for full-grown babies. So normal movements, like we said, can be seen as early on as 7 weeks. Usually all women notice movements around 20 weeks. Some primaries, especially when they have an anterior placenta, can take more time, around 22 weeks. However, the movements peak, or the peak movement, is usually from 28 to 34 weeks. And that is the time where the mothers will notice or acknowledge the movement most. Usually there's a plateau at 32 weeks, but there shouldn't be an actual reduction. It's just that the intensity of the movements is less intense, but it's always there. So by term, the number of movements is around 30 per hour. And usually, according to the circadian rhythm of the baby, the movements usually, the lack of movements don't exceed 7.
Dr. Lama, you're on mute.
Hello?
Yes, doctor, please continue. Yeah, you've been
Okay,
on mute. Yeah.
so the circadian baby, the baby has a sleeping pattern, and usually that sleeping pattern rarely exceeds 90 minutes. So when a mother complains that she hasn't felt the movement all morning, that could be a concern. Meanwhile, if she says she hasn't felt many movements for the past hours, we can actually wait. Meanwhile, we can do other studies also just to check everything is fine. Usually also mothers notice that there is a peaks of fetal movements, and usually that is after eating. So usually after the afternoon or dinner, that's the time when the babies move most. So the perception of fetal movements, most mothers feel the movement a lot more when they're lying down, a lot fewer when they're standing or sitting, because usually they'll be busy with other things. So the best time, if the mother's complaining that she's not feeling any movements, to just lie and sit on her, or lie on her side, and then monitor the movements for 30 minutes and see if she's still unhappy about the movements. And also a lot of mothers, especially mothers with who've had previous pregnancies, will say that this baby is not moving a lot. So a lot of times this could be due to the placenta, because when the placenta is on the anterior aspect of the uterine wall, it will cushion the movement, and therefore, hence, she will feel less movement. Sometimes even medications like sedatives or opioids can decrease the baby's movement because the baby can be sedated. Glucose concentrations, of course, we've seen, especially after food, babies do experience a lot of movement. Carbon dioxide, especially Women who've been either exposed to it or women who smoke, their babies can have less fetal movements. Also, if the baby's spine is towards the mother's tummy, then the movement is more towards her back, so she would be complaining of less fetal movements. Also, a proven uh, aspect of giving steroids, we give steroids for mothers at risk of preterm labor, and sometimes that has shown that mothers do complain of less fetal movements, especially with the betamethasone, and the fetal presentation has no effect. It's just the fetal position or the lie. So the issue is there hasn't been a clear definition of reduced fetal movements. So when they tried to survey the midwives and the obstetricians, nobody could have agreed what exactly to call reduced fetal movements. So there has been no greater value, and we completely depend on the maternal perception of fetal movement. And a lot of times there can be causes that we can identify when a mother complains of reduced fetal movements. Sometimes these causes can be either maternal or fetal. Maternal, like mothers who are severely anemic, who have metabolic problems, who are hypothyroid, or on some medications, like we said, some sedatives, their babies can have reduced fetal movements. Sometimes for babies, it's quite concerning when there's a fetal cause, because a lot of times it could be a sign that the placenta is not working and the baby's growth restricted, or there is not enough water around the baby, also due to the growth restriction. Or sometimes it's the exact opposite. The mother is diabetic and she has a lot of water, or what we call a polyhydramnios, and therefore it causes like a bubbling effect and she doesn't perceive the movement as much. Also, if the baby has anemia, and that's due to a problem or a discompatibility between the mother's blood and the baby's blood group, and that can cause the baby to have anemia in some conditions, and that could cause these fetal movements. Also, babies with musculoskeletal issues or inborn errors, they do exhibit less fetal movements, so the mother will complain of these. And of course, the causes of increased fetal movements, a lot of women would also complain of a lot of movement, but however, a lot of movement is not a concerning feature, and we just try to make them attentive to the timing of for example, the food, and sometimes encephalic babies that are abnormal because they don't have, part of the brain is not developed, and therefore they do exhibit uncoordinated and haphazard movement. There have been reports of fetal seizures, but those are completely rare, and that should be at the bottom of our list. So the take-home message is, remember that 55% of all cases of stillbirth are associated with risk fetal movements, and the single most common of stillbirth is, in 30% of the cases, IUGR. So this is why we can't stop emphasizing about the importance about educating women about fetal movements, and that the importance of diagnosing and managing women who come complaining of reduced fetal movements. So like we said, basically fetal movements are subjective. All the movements are maternal perception, and this is the best way. And what we try to educate women is any change in the nature of movement. We shouldn't be giving them numbers. We shouldn't be telling them, oh, count 10 numbers, because some babies, for example, 10 movements can be very less for that baby. So it's very important that the mother understands that any change in the perception of the movement. And also, she should be aware that in the event that she has less fetal movements, or she's not happy about the nature of these movements, that she needs to contact her doctor or go to seek medical attention, and should not wait for the next day. Because unfortunately, a lot of women, especially those who live far, will say, oh no, my baby hasn't moved in since yesterday, but today's my appointment, so I came today. So no, they should be aware that the moment that they're unhappy about the fetal movements and they try to lie down and monitor the movements and still no movements, they need to come in as soon as possible. Also, like we said, there isn't sufficient evidence to recommend a formal fetal movement count, because like we said, different babies have different movements, and we can't put all babies in the same range. So like we said, the most important thing is to educate women, and having a conversation with women in general about fetal movements is very important as any aspect of antenatal care and should be a pillar of antenatal care. So why not kick charts other than it's purely lazy? The thing is it was developed for high risk patients. So the majority of the population are not high risk, and therefore it doesn't really give you a good solution to their problem. Also, because it gives us a false sense of security, whether it's a mother or the physician. Oh, the baby moved 10 movements. Although the mother deep down feels that this is not enough movement for the baby, she's still quiet about it, and you're quiet because it gives you that false sense of security. So what they did is was this study where they looked at around 70,000 women and they evaluated kick charts. And interestingly, it showed no reduction in the perinatal mortality. However, in general, the mortality, not in that population, but the whole population did fall. And that suggests just a simple discussion on what's the normal of and the importance of fetal movements with the mother without the kick chart is what improved their perinatal mortality. This was a very old study, and here's a picture of the heading. So it showed that actually the once you implement the information and educate the women, it's the single best way to decrease the stillbirth, and it fell from 3 to 2 per 1,000, and that's a very significant fall. So how do we manage a woman who comes complaining of red fetal movements? First of all, we need to exclude that the baby's dead, and also we need to make sure that the baby, if the baby's alive, that it's not compromised. Also, we have identifications of cases or pregnancy cases that are high risk for adverse outcome. For example, women who are already known to be diabetic, women who are already known to be hypertensive, women with twin pregnancies. So therefore, it will help us to avoid unnecessary interventions in these women. So excluding fetal compromise, what we can do is basic assessment, including symphysis pubis height. Usually we do this in less resourceful places. Usually we start with a CTG or a computerized CTG, and this is the beauty we have in Danat, a computerized CTG. And also we check for amniotic fluid volumes, because sometimes, like we said, extremes in the volume of the water around the baby can influence the perception of the mother. Also, if we are thinking the baby could be very small, that a biometric artery Doppler is not been shown to be useful in low risk pregnancies, only in high risk. Some tests called the fibroacoustic stimulation test, and those were like probes. They used to use them on the maternal tummy. Mainly Americans use this practice. And then the ultrasound will cause a motion in the tympanic membrane of the baby and will irritate the baby and make the baby move. And that has shown completely to be useless. Biophysical profile has been shown to have no difference in the outcome unless it's a high-risk pregnancy. So basically, umbilical artery Dopplers or biophysical profiles should be reserved to women with high-risk pregnancy. If the mother is of unknown risk pregnancy, let's say you can't categorize her as high risk or low risk, always better to categorize her in high risk and get everything done, because like we said, 55% of these cases will have 30% of them, of the 55% will be IUGRs and can be at risk of intrauterine fetal death. So stuff like the history, you need to ask her how long has it? Has this been a first occurrence or it's a recurrent one? If a mother comes complaining of a recurrent fetal movement, even if she's low risk, she can be a candidate to get the uterine artery Dopplers and the biophysical profiles, the more interventions. Also, we need to make sure she didn't have received steroids in the last 48 hours. Like we said, it can be a culprit, and it has been documented that they do cause a decreased fetal movements or perception of maternal fetal movements. Also, we need to make sure the baby is viable, usually using a sonicate or an ultrasound. Also the size, and sometimes, especially if the mother is having hypertension, we need to rule out preeclampsia, and we need to check her blood pressure and check her urine for any proteins. So the very basic things is a conventional CTG. So I'm just going to discuss quickly what is the baseline. So the baseline of the CTG, if you can see my cursor, this is the baseline where you can look at the line almost going through the trace. That should be around 110 to 160. And then there's this beat to beat variability. If you can see here, the difference between every beat, and that is usually more than 5 and should be less than 25. And of course, in an antenatal trace, and this is a very, very important, there should be an acceleration, which is basically an uprising of the baseline, as you can see, by at least 15 to 20 beats and lasting for over 20 seconds. And in a 20-minute trace, we should have at least 2 if this is an antenatal trace, meaning if the mother is not in labor. And she's not in labor, the baby should have 2 accelerations because that signifies the baby is actually well and happy. And decelerations are not acceptable in an antenatal trace. Meanwhile, we tolerate them better if the baby is going through labor or the mother is going through labor, because accelerations are not usually present in labor. However, decelerations can be present and some can be interpreted as normal. Meanwhile, when you are looking at a woman who is not having any pain, she's not in labor, she should have at least these 2 accelerations and no decelerations. So the criteria we use for the intrapartum or in labor is different from the criteria we use before labor, or what we call antepartum. So what you are using now is the computerized CTG. Basically, it looks just like a regular CTG. However, there are some parameters we cannot measure or see with the naked eye. And the beauty about it is it can be very quick and efficient, because sometimes for the conventional CTG, yes, it looks good, but we want the baby more reactive, so we leave her longer. Meanwhile, the computerized CTG will tell you, no, it met criteria, this baby is fine, please discontinue. So this can be quite efficient. Also, it's quite helpful in the difficult or gray zone areas, because a lot of times there isn't frank accelerations, especially in preterm babies. You expect that, but you're not quite happy to let her off the CTG. So because it measures other parameters, it can tell you those parameters are quite normal, so it's unlikely this baby is compromised, so you will have a better feel to discontinue the CTG. Also, it's extremely useful in growth restricted babies, or what we call IUGRs, because the STV, or the short-term variability, correlates well with the ductus venosus Doppler. And any abnormality in the STV or the ductus venosus are triggers for delivery, because a lot of times these IUGRs, what happens is they're still preterm, and every day we're trying to buy time for these babies to grow, and try not to deliver them or delay delivery as much as possible. So what we do, we admit them and monitor them, and we look at the STV as a guiding for the delivery. So how does the CTG, the computerized, differ from the conventional? It's mainly the same. If one is abnormal, both are actually interpreted normal. It's just that these parameters that you can't see with your naked eye that help to predict the fetal acidemia. And I'm going to discuss it in the next slides. So some of the things we cannot see with our naked eye, but the computerized CTG reads, is the short-term variation. It's quite very crucial, high episodes and low episodes. Mainly the STV is the single most important one. High episodes are also important. Low episodes are not that as important as the other 2. So basically, the STV is the variability in the fetal heart, and that is a quite good measure for the CNS function of the baby, because it measures the fluctuation in 1/16 of a second, which is 3.75 of a second. Of a minute, so 3.75 of a second. Therefore, if the baby has an intact sympathetic and parasympathetic or CNS function, the autonomic function is fine. Most likely this baby is not compromised, because as you all are aware, acidosis impacts the baby's CNS function and the baby will be depressed. So if this is a display that the baby's CNS function is fine, it's unlikely the baby is having acidemia. Also, it's very valuable because it doesn't depend on the baseline. Some babies have naturally a low baseline, but this one is independent of that. Also, it has been shown that the low STV is strongly linked to fetal acidemia. So it's very, very important. And that's why, and then the next slide, we're going to explain, as you can see, the outcome in reference to that, to the STV, to the short-term variability. So when we're looking here at the gestational age and the STV, what if the STV is above 3, especially in all that, the likelihood of the baby dying is 0%. There is a risk of 2.7% acidemia. However, that is about 5 times more when the STV is less than 2.6, and the risk of intrauterine fetal death or death in general is 24%. So that signifies how important the STV is, especially in measuring the possibility of having acidosis and an adverse fetal outcome. So this is one of the to-go-home messages, is the STV is very important. It should always be above 3. In the event it's less, especially less than 2.6, that could be a trigger for delivery. Of course, sometimes we don't wait for 2.6. We actually deliver a lot sooner to help to avoid this bad perinatal outcome. So the high episodes are just a way to say, like, just before having an acceleration, something that looks like an acceleration but not quite an acceleration, that is interpreted by the computer. And what the beauty about it is, it depends on the gestational age, because the computerized CTG always takes the gestational age in consideration, unlike the conventional CTG, where it depends on the person reading it. Meanwhile, the computer would do the reading for you in accordance to the setup or the calibration of the computer. That's why you need to put the gestational age. Low episodes are also the same like high episodes, but kind of like a decrease from the baseline. It's not really important if the CTG overly is abnormal. Like we said, the emphasis is mainly on the STV and sometimes on the high episodes. So why we've introduced it in Danat is because like we said, 30% of all the IUFDs are IUGR babies. So we need to monitor these small babies by monitoring their STV, because it, like we said, it corresponds to the ductus venosus Doppler on the ultrasound. Also, it helps with the efficiency of the CTG monitoring in other scenarios. So indications of computerized CTG, either the babies are small or growth restricted, a mother comes complaining of less fetal movements, or she's post-dates, or she had rupture of membranes, because as you all know, preterm rupture of membranes, a lot of times their CTG is quite difficult to interpret, and that's due to sometimes some element of compression. Remember, the criteria computerized CTG uses is usually for antenatal trace and not in labor. However, we have our new CTGs now do come with a trend, and the trend does display STV, and that could be also very, very valuable. So how does it do it? It analyzes the first 10 minutes, and then every single 2 minutes later, it starts to reanalyze. So if you stop it 10 minutes before, there will be no analysis. And then the alarm usually changes color from purple to green when the criteria has met. And if it hasn't been met for 30 minutes, you need to inform her doctor. And sometimes we leave it for up to 60 minutes. If that is not met, then there are other steps we need to follow. And then the analysis will be printed out, and it will tell you why it hasn't been met. So if criteria is met, good and well, this is a perfect normal CTG. If it's not met, there's 2 categories, basically a non-reassuring and abnormal CTG. So sometimes there will be no high episodes, or like a 1 large deceleration interpreted as 20 lost beats or abnormal baseline heart rate. So basically or the STV is 3 to 5, and So the thing is, the sometimes when the machine does, there's a lot of loss of contact, it interprets that as deceleration, and therefore it will not meet criteria. So you need to make sure that there is a good interface, and that it's measuring properly, and that there is no loss of contact. And also, for a non-reassuring trace, in the event we have a non-reassuring trace, we can repeat it according to the problem or why wasn't it met. However, in abnormal CTGs, like the STV is low and there is the proper deceleration or bradycardial or sinusoidal pattern, usually there is a plan for delivery. So like conventional CTG, when it's non-reassuring, we do conventional or conservative measures, like we give fluids, we change position, we check if the trace is picking up properly, that there's no loss of contact. However, in some situations, like a lot of these IUGR babies or the growth restricted babies are inpatient and are being monitored twice a day. So if the CTG is not met because the STV is less than 4 or there is decelerations, we need to deliver these patients. However, if it just fails on the high episodes, but everything else is normal, especially the STV, then we could just repeat in 6 hours. If all the parameters fail, but the STV is more than 4 and there's no decelerations, then we could also repeat in 6 hours. So basically, like we said, we are guided by the STV measure for delivery. Usually a normal CTG will allow us to discharge a patient unless she's growth restricted and she's already being observed for that. Non-reassuring CTG will need a review, and if she's above 38 weeks or anything, we can deliver her, consider delivery. If she's less, then we need, or she's preterm, we need to consider steroids. Then we can consider also doing Dopplers in some cases to check that the baby or the placenta is functioning properly, and sometimes the liquor, because like we said, sometimes when there's less water around the baby, that can cause concerns for compression. Also, if it remains non-reassuring, we need to either repeat the above or consider for delivery. Now, for an abnormal CTG, we need to consider birth and sometimes steroids in some cases if the time allows. So exceptions, women with diabetes usually fail to meet criteria, mainly not just gestational diabetes, but mainly women who've been diabetic throughout the pregnancy. So they don't have high episodes and their CTG will fail due to high episodes, that their CTG should be regarded as normal. Also, very preterm babies, less than 28 weeks, should, even if it fails because of the high episodes, we should just consider only the STV in some cases. And now, in general, also, whether it's a conventional or a computerized CTG, sometimes the baseline of some babies is less than 110 and hovers around 100, and all the other parameters are normal. We can just consider it as a type of fetal dysarrhythmia, and then we can consult a fetal consultant or just regard it as normal. So some other methods that we can use is, like we said, the amniotic fluid, and we can check for the water around the baby to make sure that there isn't oligo, which is less water, or poly, which is more. There's two methods basically to measure the water around the baby, and that's the single deepest pool or maximum deepest pool, and the AFI, which is the fluid index. And both are measured differently, but a lot of people are going towards the single deepest pool because it's giving you less false positives. So here are some of the definitions. So when a patient is called oligohydramnios, the deepest pool is usually less than 2. If it's poly, it's above 10. Meanwhile, the AFI, it should be less than 5 and more than 25 if it is polyhydramnios. So also this is the growth. As you can see, we look at the femur length. This is the abdominal, this is the stomach. This is called the abdominal circumference, the head circumference, and the bipyramidal diameter, and the femur length. And then we plot it on a graph, and just to check if the baby is growing well or growth restricted. So usually if a mother especially usually mothers who will come complain of less fetal movements less than 24 weeks are mothers who've had babies before and are aware of movements. So all you need to do is just reassure them and check the fetal heart, or just look at the baby. Usually just scanning her like on a portable scan and seeing the baby movement gives her reassurance. Usually 24 to 28 weeks is also like quite in the gray zone, whether it's auscultation or CTG. Now late preterm, like 28 weeks, we do actually do a CTG for them. So, however, patients who are above 28 weeks, we need to do CTG. If it's normal and there's no risk factors, we shouldn't be concerned. However, if she had only one single episode of breast fetal movement, in the event that she has more than one movement, reduced fetal movement evidence, then that can be a concern. And then we could, like we said, do consider other studies like Dopplers and biophysical profile. Now, when to do the ultrasound or the growth volume if the CTG normal, but the mother still feels that she's unhappy about the fetal movement? There's no other risk factors. If there is other risk factors like diabetes, PET, preeclampsia, high blood pressure, or any complaints, if this is a multiple pregnancy or if this is a recurrent event. So these women, we can consider doing an umbilical artery Doppler. If we have concluded from the biophysical profile or from examining the mother that the baby seems small, we can also consider having a full-on growth scan, not a repeat. So recurrent fetal movements, like we said, at the practical approach, we need to exclude a growth-restricted baby or like her abnormality. We can consider doing a CTG until she is reassured. If she's already term and there isn't any issues, we can consider just delivering her. So in conclusion, reduced fetal movements are quite common. A lot of times it's benign, but however, it can be an important sign of fetal compromise and impeding fetal death. We do not advise women to use kick charts. We advise them to understand the baby's movement and monitor the nature movement and any change in the nature or frequency of the movement to seek medical attention. Also, that this is very important and they should not be delaying this complaint. Also, CTG can be a very important tool in assessing fetal condition, but also you should always take the history. Like, for example, a mother could have had experienced a fall and then she's complaining of less fetal movement. That could be concerning even if she is completely low risk. So also using an ultrasound for fetal well-being assessment, also in cases of recurrent fetal movement, also helps to reduce the adverse fetal outcomes, because we check the Dopplers and we check sometimes it could be not a diagnosed growth restricted baby, and then the fact that the mother complains of less fetal movements helps us to do that diagnosis. So this is how the computerized CTG looks like. After it prints out, this is the result. So if you can see, it says those Redman criteria met the 24 minutes. And also the signal loss, like we said, when there's a lot of signal loss, it can be interpreted as deceleration. So here the signal loss is very minute, so there was no deceleration. There were 4 accelerations, and the most important is the STV here, and it's way above 3, which is 8.9. So this is an absolutely normal computerized CTG. Now we're going to discuss some real CTGs that happened in Danat. So this patient, she came early labor, complaining of lower abdominal pain, and this is the CTG on admission. And the MRP was informed that the CTG was non-reassuring. So if anyone has any input about the CTG, that would be great. So far for this 25-minute trace, what can we conclude? Any answers? Anyone interested to answer? Okay, so basically this woman just came in admission and we saw this CTG. We should not be making conclusions. We should be continuing the trace, because this CTG doesn't look overtly abnormal. I know that these can be interpreted as decelerations, but in accordance to the new NICE guidelines, when you are having such drops from the baseline with shouldering and variability still maintained within the CTG, and this is an intrapartum CTG. Unfortunately, here it's not picking up the uterine contractions, but this woman was contracting, so it's less than 50% of the contractions. This, in accordance to the new NICE guides, so far is reassuring, and we need to continue the trace. However, it was interpreted as non-reassuring, and she was transferred to the labor ward. So this is the continuation of the same CTG. And if I'm not mistaken, even the criteria was met for the CTG, because like we said, there's shouldering, and it's less than 50% of the contractions, and the variability is maintained. So this, so far, a lot of people might interpret this as non-reassuring, but in fact it is reassuring CTG, and she will just need close monitoring. Okay, so this is the CTG in the labor ward, and also it was interpreted as abnormal. Now, if you look at the baseline has been the same at around 130, and there has been an acceleration. Yes, here there are episodes of decreased variability, but just given that this is like a 15-minute trace, we should continue monitoring. So far, we consider the CTG as now non-reassuring due to two things. That is the variability. However, the variability needs to be less than 5 to be considered non-reassuring. In, if you remember that slide, in less than 90 minutes. So when it exceeds 90 minutes, this is abnormal. So we haven't reached that, but because there's two features, we are considering it as non-reassuring. So the MRP was called because initially that CTG was considered all this time as non-reassuring. So something we call a fetal blood sampling has been done. And that is a blood sample where we take from the scalp of the baby. It's just like a glucose check, but there we fill these capillary tubes and we take the blood to be tested for acidosis. The FBS was normal, the pH of the baby was normal, and there was no acidosis. So the CTG was continued. Now, if you've noticed, there has been more non-reassuring kind of decelerations. This is what we call a biphasic. However, they are less than 50% of the contractions. So this is in less than 90 minutes. So less than 45 minutes. So this is considered as non-reassuring, and we should just continue the trace. Remember, less than an hour ago, FBS was done. So it allows us to monitor safely for another 1 hour, 30 to 60 minutes, given that 30 minutes if the CTG becomes overtly abnormal, 60 minutes if it's still non-reassuring. So now if you notice, the baby actually now it's more reassuring. The CTG here is actually, in my opinion, perfect. So the variability is nicely above 5. Of course, we don't expect accelerations given that this is an intrapartum, but there is no deceleration. A lot of times people can interpret this as a deceleration, but we need to make sure that it's not a loss of contact. In the event it's a deceleration, there is here evidence of shouldering and variability. So now this is a reassuring trace, and the patient was found to be 9 centimeter dilated. So now this trace here, variability, there is slight accelerations, variability is above 5. However, there is deep decelerations with every contraction, and they are lasting for almost a minute. So this is actually an abnormal feature. However, the patient was also was rushed at some point. They stopped hearing the fetal heart, and they rushed her for cesarean. However, in the theater, they discovered the problem was with the machine, and then they put the heart, and this was the heart rate, and then they examined the patient, and the patient was actually fully and crowning and delivered nicely. So she was admitted at 7 and delivered around 7:50 and delivered 10. So this was a rapid progress, and this is why there was evidence on the CTG of these decelerations, which could just be a sign of rapid progress. So this patient had, and the baby's pH and everything was fine. So thank you all, and the floor is open for any questions. So I've also included some of the NICE guidelines. Sorry. Hello, just gonna stop share for a moment. And any questions?
Thank you for that, Dr. Lama. Okay, so any questions for Dr. Lama? Please feel free to open your microphone or open your video. We can have an interactive discussion with Dr. Lama, or if you wish to post your questions in the chat box, and we can ask that to Dr. Lama. Also, just a reminder to everyone, please make sure that you answer the pre-test, post-test, and evaluation form. The link is posted in the chat box. And also we have posted the email address for any questions regarding your certificates. So Dr. Lama, you will be sharing the slide with the guidelines, right?
Not just the new NICE guidelines that
Okay.
were incorporated. Just anyone has any questions so far?
So far, we haven't received any questions, but Dr. Mariam would like to express her appreciation for this excellent presentation. Hello, Dr. Mariam.
Hi, good morning, everybody.
Good morning, Doctor.
Thank you, Dr. Lama. It was excellent presentation and so useful.
My pleasure, Dr. Amar.
And welcome back.
Thank you so much. Thank you so much for your appreciation. Our concept, especially Dr. Mariam is aware, we're trying our best to decrease our our primary cesarean section rates. So hopefully we're doing these educational sessions every month, and a lot of times we are using reference CTGs from the actual from DANAT, and the purpose is to help educate as much as possible about CTG and interpretation of CTG, hopefully, and then allowing people to be more tolerant of changes, because the NICE guidelines, the latest NICE guidelines have completely changed a lot of aspects of how we define the CTG and the changes. So especially our tolerance for the decelerations. So I don't know, can you see my screen now?
Yes, doctor.
Yes,
So I think
yeah. So this is the latest NICE guidelines about the interpretation of a CTG. So basically, they've changed when it comes to the decelerations. So they've considered before any deceleration was considered as a non-reassuring feature. Meanwhile, the latest guideline is that if there's a deceleration with no concerning characteristics for less than 90 minutes, that is still considered normal. And the concerning features are if it's lasting over 60 seconds, which is like an equivalent of a 1 minute, if there's a reduction in the baseline variability within the deceleration, i.e. there's a loss of the variability. Also, if it doesn't return to the normal baseline, or if it's a W or biphasic shape and there's no shouldering. So that's why the CTG that we saw was interpreted by some group of people as abnormal. Meanwhile, it's actually normal, and the other people considered it as normal. And the biggest evidence it was normal is when the FPS was undergone, the sample was normal. Also, it comes only non-reassuring if it is lasting for over 30 minutes, or if there is concerning features in 50% of the contractions for up to 30 minutes. And all these new guidelines, allows us to be more tolerant to these changes. So not every CTG we find any deceleration and we should immediately consider taking her for a C-section. We need to come and look at the overall trace, the overall risk of the patient before we make such a decision. because not only that this is a primary cesarean section, remember that our population are extremely fertile and they love to have a lot of kids. So we should be advocates of normal delivery, and this is available on the NICE guidelines. You can find them easily. Just type in NICE guidelines on CTG and you can see these a new one there. So this is what I just wanted to add, and because it's very different from the old one. And thank you all for joining. If anyone has any questions. Okay, so I think we can conclude, Cherry.
Yes, doctor. So far we don't have any further questions. Just a lot of people expressing appreciation for this great chunk of information.
Yeah, it was a big chunk, I do admit.
But it's good, to imparting all this updated information to our OBs and midwives and all the nurses, so that we can minimize the mortality rate, as you've mentioned, and for the antenatal care of our pregnant mothers.
Yes, so
Yes.
basically the best thing we can do is educate the mother about the importance of fetal movement in the event she experiences any difference at all in the nature of her baby's movement, to come seek medical attention immediately and not delay. This is very important.
Agreeing with you, doctor.
Okay, I think we can
Yes.
conclude.
Okay, I think we can conclude our CME this morning. And then again, if you have any questions regarding your certificates, please feel free to send an email to the email address that Tahira will be posting in our chat box. And there's also a guide. She will be guiding you as well for securing your certificates. Once again, thank you very much, Dr. Lama, and thank you everyone who has attended our CME this morning. Last words, Dr. Lama?
It's okay. Thank you so much. And this is actually a monthly thing, but we just wanted to reach more people out. But we do this actually every month. So please join us also for next month, where we'll have new CTGs to discuss.
Great.
And if anyone comes across an interesting case or a CTG, please let us know.
Okay. Thank you very much, everyone. Thank you very much, Dr. Lama.
Pleasure. Bye. Have a good day. Bye-bye.
Bye-bye.